hematologist there, and then eventually I was referred to AIMS. So I got to know that it's a very complex disease, and since I am a non-medical, I have been trying, and a researcher. I have lived in USA and studied in USA, worked for international organizations for over 10 years. So I had an understanding of policy, prescription, and tools. So I got into this to understand that how this disease can be fatal. So it is in this light I want to request our patron, who is an institution builder and who runs a couple of universities, who is chancellor, Dr. Professor P.R. Trivedi Sahab. Probably if he is there, I don't know. Is he there? Professor P.R. Trivedi Sahab. Professor P.R. Trivedi Sahab. I think he is in. He is in uh, a different place. Probably he's not able to join. So now, to precisely, I will request Dr. Uday, Dr. Pankaj Malhotra Sahab, who have really acknowledged the existence of amyloidosis support group of India for the first time, and they had been my doctor, and they had been a great support to me. It has been a very bad time we are still faced with, but I believe that we'll all come out and India will emerge as the best center, and several centers in India can come up to handle this disease. So since Dr. Professor Trivedi Saab is in Dehradun, I will try to get in touch with him. In between, I request, because just now I came from chemotherapy, so I will request Dr. Uday Sahab, who has been professionally running this group, and whatever we are today, it is because of the blessings of image and many doctors, almost all the doctors, hematologists and nephrologists, cardiologists. It will be very difficult to tell the name of everybody, but right from Max Hospital to Fortis to Artemis to AIMS to PGI Chandigarh to Lucknow, to everybody, the doctors who had been great with us, and we have been able to gradually get the support of the government. Today we are having the government representative from Director General Health Services, and the Director General Health Services is also, he has been very kind. He convened a meeting, and we are really privileged that Honorable Prime Minister of India, he showed a lot of interest. We had sent our papers to him, and he responded immediately, and he is also overseeing our activities. And we are blessed that way that Honorable PMO and through the ministry secretary was also available today, but she has certain other important tasks. So but she has called me after 30th of October, and Director General Health Services, the Secretary Health, all are taking keen interest in finding solutions to this problem. So with this background, there is a joint secretary calling from Ministry of Health. So just, yes, madam. Yes, madam. We have already started the meeting. So we will you join, or your secretary will join? Hello? Hello? Ma'am, we are already in the meeting. We are sending you the link. Just. Actually, Joint Secretary Rare Diseases, she is in the middle of her daughter's marriage in Chennai. And Secretary Madam was kind that she would have come personally. So, sir, without wasting time, I will request Dr. Uday, because just now I came from chemotherapy, sir, whole day I was having very hectic day. So we need mixing of doctors, hematologists, all the doctors of India. And we only pray that today we are close to Diwali. You all doctors, sir, give us a gift that we mitigate, manage this disease and eradicate this disease from India. And I remember so many sentences that every time we think of something, solutions outside, but the solutions are very much in India, sir. You all are brightest minds of India in the medical science. So I don't have much to say. We are a small group. We are non-medical. We have 18 patients. We have 136 members. We have majority of the best doctors of the country and from different disciplines. And we are growing, sir. We are trying to reach out to as many people as possible. We are launching the patient portal. We are trying to establish registry. We are requesting the ministry to take over the ASGI. We are requesting IMES to take over the ASGI because for sir, it's gradually growing big and challenges are very crucial, sir. It is very difficult to at times to even share within the family and outside because the complexities of the symptoms, it flows with the blood. So it traverses throughout the body and it really affects. So with this background, sir, the structure of the format is that we had thought that we will have blessings of our patron, Professor P.R. Trivedi. He will join probably, sir, within few minutes. I will request him. But you will be moderating the whole show, sir, for us. And you can give an opportunity to the ministry representative. We have identified Dr. Rahul Bhargav Sahab who agreed to speak, and also Madam Dr. Tulka Seth. I have requested. She is my doctor. I have requested her. We have got willingness of Dr. B.S. Vivek from Gangaram Hospital, who thought that he will give his perspective. Then we have one doctor who has been seeing me regularly, Dr. Rodney Espalk from Harvard. I have been in touch with him for last 2 years, and we have requested if he can join. Otherwise, sir, we don't have in technical sessions, except you, Pankaj Malhotra Sahib, and other doctors, we don't have many. And then, sir, with this technical session, around 8:30, we have 2 moderators from Amyloidosis Support Group of India. The oldest patient of amyloidosis who has started this support group, Mr. Atul Pandya Sahab, and one bright professional company secretary, Madam Shriya Singh. But the whole event has been managed by Nabodita Seth and her company. They are the social entrepreneur, and they had taken this assignment, sir, and they have done it very professionally. So with this, sir, I give मैं अपने शब्दों का विराम देता हूँ. अब सर till 9:30 I hand over everything to you. So with request to Dr. Colonel Uday Saab.
Good evening, all. So firstly, I would like to wish everyone a very happy Amyloidosis Day. Today happens to be a World Amyloidosis Day. Now, I bring the greetings on behalf of Indian Myeloma Academic Group, and we have a chapter. So I will say both in Hindi and English for everybody's benefit. So we have a amyloidosis chapter, which is primarily handled by Dr. Gurleen, who has consented kindly to join the meeting today, along with Dr. These are the people who are trying to work on the technical front, because we understand आपके जितने भी सवाल हैं उनके कईयों के जवाब हमारे पास एज ऑफ नाउ हिंदुस्तान में नहीं है. कई चीजें ऐसी चीजें हैं जो आज तक हमारे पास इस देश में टाइपिंग ऑफ एमोलॉइडोसिस की किस तरह का एमोलॉइड होता है और किस तरह की बीमारी किस पेशेंट में है, वो पहले क्यों नहीं डायग्नोज हो पा रहा है, हम मतलब लेट क्यों डायग्नोज कर पा रहे हैं, अर्ली डायग्नोसिस के लिए क्या किया जा सकता है. सो इन सारी चीजों पे आप जितने तरह से भावुक हैं और जितने तरह से तत्पर हैं कि मतलब इन सवालों के जवाब ढूंढे, हम भी उतने ही तत्पर हैं इन सवालों के जवाब ढूंढने में. हम भी चाहते हैं कि इन सवालों के जवाब जल्द से जल्द मिले. We get these answers as early as possible, and if we can do something from the image end, wherein we can start off with an early diagnosis. So last year we happened to meet the founder of the ASGI, Satish Chandra ji. He had shown a huge interest, and he has been anchor for this particular group which is there in the country. And we are very, very happy and extremely proud to say that he is one person who has been the driving force for the complete amyloidosis. And we fully acknowledge this. We have had a MOU or a sort of agreement with ASGI that we will support them technically in all their activities, whatever they are going to do. I'm also happy to announce from last year to this year, we also had a last year World Amyloidosis meeting, जिसमें Dr. Shaji from Mayo had joined. उससे लेके आज तक जैसे आप सोच सकते हैं कि एमोलॉइड के फील्ड में क्या हुआ एक साल में, तो I will slightly enumerate what all we have been able to achieve in 1 year. But the most important achievement has been a book written by Satish Chandraji, wherein he has covered every aspect of the amyloidosis, from clinical features to various organ involvements to how to diagnose and other things. So for any layperson who really has no understanding of what amyloidosis journey is all about, so a just overview of that particular book can actually give a quick review that what a patient can expect from the disease and how the disease progresses, what all it can cause. So I congratulate from the bottom of my heart Satish Chandraji for putting that effort of putting it up all together and bringing out a book which is around 180 to 200 pages, covering every aspect of amyloid. It's not only for the patients, even for the young doctors. It's a good quick review about how to deal with amyloidosis and what amyloidosis means. So that's the first part. Now, from the technical part or from the Indian Myeloma Academic Group front, we have announced in January this year a amyloid chapter, which is primarily held by Dr. Sumit Mith from Tata Memorial Hospital in Mumbai and Dr. Gurleen from Delhi. She earlier was part of Lalpat Labs. She was a senior consultant there, and now she has joined the Medanta group. So these two people have been trying to work on the technical front or the academic front of the amyloid. So they have summarized all the studies which have taken place, because the first thing which happens in the country is to understand कि भाई अभी तक इस फील्ड में क्या रिसर्च हुआ है और आगे क्या होना है. So from the clinical side, Dr. Sumit Mirg had put in all that together, and from the pathology side or from the diagnostic sides, Dr. Gurleen has put the things together to understand what have we done till today and what is pending or what more needs to be done. So that's first part of the story. Second part of the story is in the country, Amrita Institute of Medical Sciences, Kochi, has been the first center to have a comprehensive amyloid clinic. We have encouraged this year almost around 11 people to participate in the amyloidosis meeting at Mayo Clinic in Rochester, of which around 3 doctors were able to travel all the way to Mayo Clinic, Rochester, understand the nuances of it, and were able to understand what is the latest as far as amyloidosis is concerned. So we could support that from Indian Myeloma Academic Group for these doctors to travel to Mayo Clinic and understand the newer perspectives. After that particular meeting, Amrita Institute has come up with a comprehensive care center. They have a cardiology center also, but they have a detailed amyloidosis care center wherein they take care of all aspects of amyloidosis. We are also looking forward that we have similar comprehensive centers across the country. So we have requested Dr. Neeraj Siddharthan to kindly take this movement forward and to help the various centers in the country to come up with comprehensive amyloid centers so that the diagnosis is not delayed, because this disease presents to different doctors and all of them understand the nuances. We require comprehensive centers. So that is the second. Now, the third thing, as far as amyloidosis is concerned, is we are coming up with mass spectrometry. Now, in the country, there are around 18 centers who have been working on mass spectrometry in amyloidosis, starting from my center in Pune to PGI Chandigarh to Dr. Rahul Bhagar's center to Dinanath Mangeshkar. There are a number of centers who have procured mass spectrometry equipment, and they are all trying to develop the various diagnostic modalities to diagnose or type the amyloidosis. I understand it's not possible in the next few months to occur, but in the years to come, definitely we are going to have amyloidosis diagnosis within our country, and the typing and exactly what type of amyloidosis we are dealing with should be a near possibility. So we expect in next maybe year and a half, have these facilities in our country itself. That's the next thing that I wanted to announce. The last thing which I wanted to talk about was about increasing awareness. So we want ASGI to actually come up with more and more patient group meetings and more awareness, and to have chapters in all the states, and wherein they can actually come up, they can talk to. We will try to connect ASGI with the primary centers in the country which deal with amyloidosis, because this happens to be a plasma cell dyscrasia. So our doctors, that is Dr. Sumit and Dr. Gurleen, will get in touch with Satish Chandraji and the team to take it forward, and we can have the registry that you are thinking of. We also have started collecting the data, and we have started creating registry. We already have a platform, and we are collecting all the cases across the country. So rather than reinventing the wheel, what we would suggest from Indian Myeloma Academic Group is that all the patients that once we identify that they are suffering from amyloid, we want them to get in touch with ASGI so that they get a support or a emotional and a moral support from the ASGI. Because as doctors, it's not possible for us in a limited amount of time that we have during the interaction to explain every aspect of it. It's always good that other patients who have gone through the disease or who have successfully fought the disease as warriors, I would call all of you people as amyloid warriors, to explain the goods and bads of it, such that you provide that emotional support to these people. So as Indian Myeloma Academic Group, our team will definitely try to put across all the amyloid patients across the country, and will get them registered with ASGI so that they can get emotional support and the psychological support from your group. So that's something which we are in the process of doing. So most probably by mid of next year, we will have our registry completed, and we will have most probably all the cases across the country put under one umbrella. So we want them to get connected with ASGI. Now, as Satish Chandraji was saying that image should take it over or health ministry should take it over, we are of a different feeling from Indian Myeloma Academic Group. So we have dealt with so many patient groups in various fields of hematology and oncology. The best way a patient group survives or is taken forward is by patient themselves. So it's for the patients, by the patients. So it is something which should not go into any technical hands or government hands, because the empathy part of it will not be there. We can only have sympathy towards the patient, but empathy can only come in from one patient to another patient. And they would be the best people to explain to another patient how they actually feel through. Many a times, many doctors might get perturbed by looking at it when some patients say, "Yaar, hame itna ghumna pada." But that's the truth. That is what most of the time it happens to the patients. So it's always good that one patient explains the agony or gives a moral support to another patient about how to handle such situations, rather than the doctors or the government or ministry doing it. Yes, we are there to support ASGI, but we always feel that this is going to be an external support. And we actually have an excellent person with us, a non-medical person who handles most of our efforts, who is Mr. Praveen Jha. So we have requested Mr. Praveen Jha also to closely communicate and deal with the ASGI, so that whatever are the technical deficiencies or the lacuna which you want us to fill in, we are more than happy to fill in. So I would like to stop here. Before, I would like to give chance to the other people in the today's program. So I will hand it over to Nivedita to see if there are the patron and the members from the ministry are here to contribute their bit. Otherwise, we have Dr. Gurleen and Dr. Sumit who will give their purview about what they have done in the last 1 year for amyloidosis. So over to Nivedita, please.
Hello. Dr.
Yes,
P.R.
Ms. Nivedita, we
Trivedi?
can hear you. Please go ahead.
Yeah. So I would request if Dr. P.R. Trivedi is here, please join. Sir, I don't think they're here.
Proceed with the schedule like
Yes,
as
sir.
Do we have the members from the... Yeah, Chandraji, please go ahead.
Yes, sir. No, we members from ASGI, sir. We have, sir. We have. Like now, we were hoping, sir, if Dr. Rahul Bhargava Sahab, Dr. V.S. Vivek, and Dr. Tulika Seth, Madam, if they were available and if they can, because Dr. P.R. Trivedi Sahab is in Dehradun on a religious trip, so probably he might be busy. So if sir they are there, otherwise your team can take over. Sir. This is
Um, Good evening, everyone. Dr.
Sure. If we are, yeah, if we are waiting, yeah, please.
Yeah, I'm Dr. Vivek, cardiologist, and as uh, Satish sir was mentioning about one of us pitching in, so I would, I can go ahead and speak on it if I am told what specific thing is required of me. What insight can am I supposed to present, or else others can start and then I can also chip in.
in fact, sir, your perspective was
Thank you, Dr.
solicited.
Vivek, for being part of it.
Let's say. So, TG, you were saying something?
Permission of
Hello?
Dr. Uday. Actually, sir, we had requested Dr. Vivek, Dr. Madam Tulika Seth, Madam, and Dr. Rodney Falk and Dr. Rahul Bhargav Sahab to give their perspective if they were available.
So, firstly,
Uh,
I would like to thank Dr. Vivek for joining the meeting and sparing your time. So, Dr. Vivek, I think you can just take it forward from your perspective when you see patients in cardiology. So, how do these patients of amyloidosis come to you? And amyloid patients has a cardiac involvement. How do you take it further? And if you can just explain that for the benefit of the patients, that would be really great.
okay, so the general overview of a patient who may be potentially suffering from cardiac or systemic amyloidosis is when we are referred. This is basically a situation wherein um, we are called upon to evaluate a person who is already being seen and investigated, usually for an average of at least a year or more, in which they have been, usually a couple of hospital stays, a couple of um, places where they have been, going from one pillar to post, trying to find an answer of their symptoms, which usually is breathlessness. And then gradually this breathlessness is so gradually progressive, and then starts accumulating as fluid in the limbs. And then people who have been investigating, including cardiologists, at times may not have this as a differential diagnosis. So by the time they are referred to us, they've mostly been investigated thoroughly, and in terms of at least 2 or 3 echoes have been done, multiple ECGs, multiple blood tests, and then they have not been able to put a finger to what is the cause of their progressive breathlessness, which just doesn't seem to respond to the usual treatment that is meted out to patients with congestive cardiac failure. So that is the situation I have been facing the last 4 to 5 years that I have taken a keen interest in this. And even prior to that, maybe even I was not being watchful enough, and maybe even I have missed certain patients. But nowadays, once that uh, we have a cardiac amyloidosis sort of a program going on in Gangaram Hospital, so we are very careful, and people are referring us to patients where they feel that this is not a breathlessness of simple congestive heart failure, but there is something more to it. So that is when we start with our basic investigations, the ECG, the NT-proBNPs, and the most important of which is echocardiography. And I like to do the echocardiography of a person who's suspected. Either I have been seeing that patient, or that patient has been referred to me personally or to our center, suspecting even there is a slightest red flag that it could be amyloidosis. I like to do it individually, as this is a very subjective test. Echocardiograms, good echocardiographers also, if they have I've seen often that if they have not kept this in their mind, the eyes do not see it. The eyes see what the mind knows. And that way, after basic investigations, which are not very pathognomic for amyloidosis, the first important test that we do is an echo. And there are lots of signs and techniques wherein we can pinpoint to great extent that we are dealing with amyloidosis. But then the issue comes which form of amyloidosis, where we have these routine serum and the urine immunoassays. And once that we are trying to basically look for the AL amyloid. And once that has been ruled out, then we have the PYP scan in our nuclear medicine center. And since our center people, we have done about 50 patients screening, all of which were actually patients who were in all red flags supposed to be pointing towards amyloidosis, and yet we found only 24 of them, which happens to be the largest series in our NCR, who had positive, most of which were AL. So the protocol that we are following, we are a closely knit group of doctors who have a special interest in amyloid, and any of one of us, one is a hematologist, the other is this nuclear medicine scan specialist. From the cardiac side, I'm there, and there is a nephrologist and a neurologist. So that way we have been broadening our REAM into trying to not miss a patient who comes with an undifferentiated diagnosis, possibly amyloid. And once the serum immunoassays, the urine immunoassays have not pointed out that they say that the AL is not there, that is when we take a PYP scan. The nuclear medicine person has also become an expert now. There is a learning curve to it. All these tests are subjective interpretations to some extent. So we need a PYP with a PET CT available in our center. And once then we differentiate it, then we go about treating it. So this is the broad. We are trying to make a small effort in not missing a disease which unfortunately in our country, and even till about 7 to 8 years in national conventions, been in touch with certain Italians and English person. They say that this is what they were facing about 10 years back from now, not too back, in which patients were missed for amyloid early detection. But now they have a running program, and as the ASGI, there are other bodies in there, for example, the US, and all these have a very active amyloid groups, and these are all patient as well as doctor groups. And I feel that the venture initiated by Satish is in that particular stream of thinking and going about this situation. I think this is the right track on which we have started, and I hope that this becomes something which develops into the fine groups that are available now, especially in US, where the doctors, the physicians, and all the stakeholders are actively putting their efforts. Thank you. I'm open to a specific question, if any, in the group. Otherwise, I'd rather now ask Satish Ji to take over and let us know the next part of the agenda.
Now, actually, sir, Trivedi Sahab probably has joined. If he has not, then I request Dr. Colonel Uday Sahab to continue as a moderator and chair for this entire session. And then we want only, sir, 1 hour for Q&A from ASGI perspective, or 40 minutes from by Atul Pandya Sahab and Madam Shreya, and concluding remarks by Navodita Seth, Madam. So handing over to Uday Sahab, sir, you proceed. We have two speakers, Dr. Rahul Bhargava Saab, Madam Tulika Seth, and Rodney Falk, if he's there, Dr. Saab, then probably, sir. These are only three participants we have requested.
So thank you, Satish Chandraji. Thanks a lot, Dr. Vivek, for your insights into it. Now, there are a few queries before I open the forum for the audience and for the patients to ask. So, some few technical queries. When you said that you have done PYP scans for around 50 and you found 24, so that only picks up ATTR amyloid. So still, we will miss upon the AL amyloidosis in PYP. So what's your experience about picking up AL amyloidosis on PYPs?
No. So, as I said, first of all, we first rule out the AL. First and foremost is an immunoassay. Now, once the immunoassay points that it is an AL, we don't need to go for a PYP scan because world over about 15 to 20% patients of AL will also be having a positive PYP scan, but they still fall into the AL variant because it is well known that although this is a characteristic of ATTR, the PYP scan, but about 10 to 20% patients are known to, even of AL, to show a bright scintigraphy spot in PYP scans. So we don't venture into PYP scan if the AL has already been diagnosed. Otherwise, it will create a confusion. There are others who get it done routinely, both the immunoassays for AL and simultaneously PYP scan. And then there is the scope of confusion. So not only does it add to the costs of the test, each test is expensive. So for instance, if the patient has an AL and we get both tests done simultaneously, AL and PYP, I mean immunoassays and PYP scan, and not only are we adding to the costs, but if that AL is there and PYP unfortunately comes positive, then it leaves the physician in a dilemma whether we are dealing with an AL. So worldwide it has been accepted that if AL immunoassay is positive, and even if PYP is positive, you treat it as AL, and because that is the more lethal variant, and then worry about after a couple of years whether we are actually dealing with ATTR. So it's not that we go directly for PYP. Right.
Yeah, excellent. So, I basically want that to be clarified for the patients and for the audience who are here.
Yes.
So, just for that particular sake, for them to
Sure.
understand that in patients with AL amyloidosis, we generally do not go for PYPs. So that point is brought forward very clearly. Now, also, I would like to ask you your expert opinion about the role of cardiac MRI in patients with amyloidosis to rule out cardiac involvement.
Yes, so this is a very useful test. The Germans, so they have about many guidelines across the globe. There are 6 different guidelines by different societies: the Americans, the Canadians, the Japanese, the Germans, the Europeans. So it is the Germans who have got one algorithm in which the whole diagnosis can be based on cardiac MRI alone. Otherwise, most of the times, considering the costs, the expertise, and which is more relevant in our country, cardiac MRI is basically left for those uncertain patients where you have a clinical suspicion of amyloid, but none of your scans or your tests are actually coming forth with a definite result. So only in those gray areas that you take a help of cardiac MRI, which by itself, and again, cardiac MRI is being done increasingly commonly across at least our Delhi NCR and in other cities. But then that also has a learning curve. There is an expertise, and then there are softwares which needs to be updated when we are talking of the ECF volume analysis. So that is not available in all MRI scanning machines. So cardiac MRI should be reserved, considering its prohibitive costs, only if there is a gray area, and we just can't rule out amyloid because our PYP was borderline or negative, or the lambda and kappa were not very forthcoming. So that is where I think the second place, if cost is not a problem for a given particular patient, then you can individualize it get a baseline MRI done and use that baseline MRI to assess whether the treatment that is being given is being effective. So that is for prognosis. That obviously cannot be a routine thing in our country. It's a very expensive test. But world over, where cost may not be that big a factor, people are using it for prognostication also, in which they measure the ECG volumes and other parameters and see whether the treatment has had an effective outcome in terms of cardiac MRI findings getting better. So.
Thanks a lot for bringing it out very categorically, the relevance of cardiac MRI. Now, also, I would want you to comment about the people who are doing echo, and particularly for the patients, the difference between the systolic function and the diastolic dysfunction, because whenever the patients of amyloid, they generally end up with an echocardiographic or with a cardiologist who is doing an echo, just commenting on the systolic function versus commenting on diastolic function, the relevance of it in the amyloid patients.
So amyloid basically is a prototype of a restrictive cardiac disease. Restrictive means there is a restriction to filling of the ventricle. The ventricles are ejecting and filling, two important functions. As you said, systolic function is ejection fraction, how the heart pumps the blood out of it, and the other part is how it fills itself. So restrictive diseases means there is a restriction in filling. So in most instances, until it gets to an end stage, the systolic functions are always going to be preserved when we talk of ejection fraction as a parameter to assess the systolic function. So systolic function is going to be preserved, but it's the diastolic dysfunction which is more important. Again, diastolic dysfunction can be seen in many other diseases which are not restrictive cardiomyopathy or not amyloid. So when we talk of amyloid's diastolic dysfunction, you cannot actually separate it from many other diseases, because if you just take a diastolic parameter and present it to me and say that this patient has a grade 3 diastolic dysfunction, I cannot say whether it is an amyloid or any other disease. So it is a congregation of not only the systolic ejection fraction measurement and diastolic filling measurement, but then it takes many more aspects over and above systolic function or diastolic function. And that is where there is a technique called global longitude. There is a, I don't know whether I'm audible or not, the call just came through. That is where we have global longitudinal strain measurement, GLS. Now that is pathognomic at many times. Also, the thickened muscle, the sparkling nature of the muscle, so it's the texture of the muscle that you are seeing, and also the GLS, which has a typical cherry on top appearance. Obviously, that's a technical thing. So when we are doing an echo of a possible amyloid, systolic function is usually preserved until unless that it has gone into a complete end stage disease. That time rarely even the systolic pumping functions can also start getting reduced. But characteristically, it is a diastolic or restrictive dysfunction of the muscles. Diastolic dysfunction alone cannot categorize into an amyloid, so you have to take into the texture of the muscle, the thickening of the muscle, and most importantly, the GLS, the typical reduced GLS of
Hello. Yeah, Dr. Vivek.
I don't know if I'm audible.
Yeah. We just lost it, statement, but I think you were more or less clear on that. What are the various 2D echo abnormalities? Now, this is primarily for the patient that please ask. Yeah, Dr. Vivek, you are still saying something?
I'm sorry, sir, I'm not.
Okay, I'll just continue. So what Dr. Vivek tried to clarify to various people is, when you go for getting an echo done and see that ki just ejection fraction normal hai, that is not sufficient enough. There are so many other factors which play in when a cardiologist looks for a case of amyloidosis. So the doctors are, what he was trying to say is ki, firstly, the thickness of the wall. Then इसके बाद एक apical sparing होता है कि एक particular part of the heart is generally spared in amyloid. Then texture of the myocardium, जो आपके हार्ट के मसल्स है, उसके टेक्सचर से भी हमें समझ में आता है कि किस तरह का मतलब ये एमालॉइड में इन्वॉल्व है या नहीं है. देन एट्रिया, जो लेफ्ट एट्रिया होती है, जो जिससे मतलब ना खून अंदर आता है, इवन उसमें वो भी डायलेट हो सकता है इन पेशेंट्स में. एक ग्लोबल लॉन्गिट्यूडनल स्ट्रेन करके होता है, जो जीएलएस या जेएलएफ बोलते हैं. तो वो एक अलग पैरामीटर होती है जिससे मतलब समझ में आता है कि एमालॉइड से कितना फर्क पड़ा है. And also, जैसे वो स्टारी स्काई और what he was trying to say, the type of pattern that echo में जैसे intensities नजर आती है. So amyloid का जब 2D echo आप करते हैं, so there are many factors which are looked into just other than the ejection fraction. Because most of you, when you come to us, to the hematologist or oncologist, you saying कि सर देखो पिछले बार भी ejection fraction 40% था, अभी भी 40% है, लेकिन मेरे चलने की ताकत कम हो गई है, मेरा सांस फूलना बढ़ गया है. So it is just not ejection fraction which matters. There are many other parameters which are there which needs to be looked into by a cardiologist, and they often look into it for commenting about whether your disease is in control or your disease is worsening. So that's something which we are thankful to Dr. Vivek for explaining the various echo abnormalities. So just that's what about echo. Second, उन्होंने MRI के बारे में क्लैरिफाई किया, और थर्ड उन्होंने PYP स्कैनिंग की किस पेशेंट में जरूरत है और किस पेशेंट में जरूरत नहीं है, उसके बारे में भी डॉक्टर विवेक ने बहुत अच्छी तरह से समझाया कि वो कहाँ-कहाँ फर्क पड़ता है. So these are the various aspects which are there. Now there is one question in the chat box which I would like to ask you, Dr. Vivek. Though this I will also be answering partly. So Mr. Atul Pandya ji wanted to know कि transplant की suitability के लिए most often the decision is based on the cardiac condition. So whether a patient is fit for transplant or not, as a hematologist, we only take up when they are cardiologically fit for transplant. So he says NT-proBNP and other biomarkers are usually done. So they wanted to have more understanding about the role of these biomarkers in understanding cardiac condition. So please go ahead. Once you complete, then I will also comment on it.
Okay, the role of biomarkers is such that troponin and NT-proBNP. Now, these two parameters are the ones which are assessed across the world. They have been, Mayo Clinic has given certain classifications based on how it is to be interpreted. Unfortunately, NT-proBNP in a typical amyloid is always going to be high, and some people who do not get a reduction in NT-proBNP should not be discouraged. NT-proBNP is only one of the markers. Sometimes there is a lag in it. You may clinically improve, but your NT-proBNP may remain on the higher side. So that is one important prognostic marker, but then it has the specificity of it is not very good. So इसका अगर ये बढ़ा हुआ है तो don't panic about it. People have used it for prognosis. Troponin I is a lesser used thing, but then again this also has almost an equal importance to NT-proBNP. NT-proBNP it can be affected by other conditions. Sepsis अगर हो गया है, किसी को infection हो रहा है, या there are so many other COPD, अगर कोई चीज कोई ailment lungs का शुरू हो गया है, उसमें भी कई बार बढ़ जाता है. अकेला NT-proBNP should not cause us to panic is what I feel. Sir.
Yeah.
Thank you, sir. Thank you.
Thanks a lot for clarifying that. In fact, NT-proBNP as well. So hope I answered you, Pandya ji.
Hello, sir.
Yeah,
Hello.
Pandya ji, please go ahead.
The question is that basically myself and Dr. Satish Chandra is more emotionally attached with the all participants, and we have received so many questions for our group as well as from others who are suffering from amyloidosis since last 3-4 years. So one of the questions which is coming very frequently from the patients, that the suitability for ABMT. Second question is that most of the patients have suffered from the cardiac amyloidosis, and they may have advised by the doctor because their cardiac situation is not good, they are not fit for the ABMT. So for us, we are not a technical doctors persons, but we from our logic, from whatever we learn from the Google, we try to advise them. We need, because we have experts here, we need for entire forum some lights on this thing. What is the particularly cardiac amyloidosis severity versus the suitability of the ABMT, and suppose ABMT is not possible, what are the best chances to survive or having the better lifestyle to live with the amyloidosis? I hope you can understand me.
Yeah, you are absolutely clear in your query and in your question. So thanks for clarifying that. So firstly, I will answer the first part of it. So amyloidosis is a POSI chain disorder. So that means जो इसके अंदर डिस्प्रोटीनीमिया या जो प्लाज्मा सेल डिस्क्रेजिया कंपोनेंट है वो माइलोमा की तरह बहुत ज्यादा इन्वॉल्व नहीं होता है. सो इसके अंदर जो प्लाज्मा चेन्स, जो प्लाज्मा सेल्स आपके जो एबनॉर्मल प्रोटीन प्रोड्यूस कर रही है, उनकी क्वांटिटी जनरली बहुत कम होती है. हम जो ट्रांसप्लांट करते हैं, ट्रांसप्लांट का पर्पस ये होता है, ये जो प्लाज्मा सेल्स जो एबनॉर्मल प्रोटीन प्रोड्यूस कर रही है उनको हमें रोकना है. सो ट्रांसप्लांट प्राइमरली हेल्प्स in preventing progression of disease, but under no circumstances that it lead to regression of the organs which are already damaged or which have been involved by the amyloid per se, because amyloid is an extracellular deposition of this protein. So जो ये extracellular deposit हो गया, उसको हम लोग transplant के द्वारा हम लोग उसको वापस ठीक नहीं कर सकते हैं. Now your question, first part of it, which was very clear, is what is the criteria to say a person is fit for transplant or not. So first of all, in amyloidosis patients, these patients can be taken up for upfront transplant. That means in patients को chemotherapy की mandatory जरूरत नहीं होती है. So if the plasma cell load is not much, they can be directly taken up for transplant. Now why am I bringing this? Because with every passing day, there is a chance of disease progressing and of whatever is the organ involved, that organ impairment increasing. So with the increasing organ impairment, whether it is kidney, whether it is heart, so the eligibility for transplant keeps coming down. So the earlier we transplant, the better it is. Point number one. Point number two, as I just mentioned, we have something known as the HCT-CI scoring. It means hematopoietic सेल ट्रांसप्लांटेशन कोमॉर्बिडिटी इंडेक्स, जिसके अंदर हम 4-5 चीजें ब्रॉडली देखते हैं. वी सी हाउ द पेशेंट्स किडनीज आर. सो वी डू बोथ डीटीपीए डीएमएसए कि भाई किडनी का फंक्शन कैसा है, कि स्ट्रक्चरली, कि मतलब देखने में वो ठीक ठाक है या नहीं है, और उनकी फंक्शन, सो एनाटॉमिकली एंड फिजियोलॉजिकली वो बराबर यूरिन प्रोड्यूस कर रही है नहीं कर रही है, शरीर से एग्जैक्ट अमाउंट ऑफ यूरिया एंड क्रिएटिनिन वो बाहर कर रही है या नहीं कर रही है. So ये हम दो स्कैनिंग से करते हैं. Cardiac functions, we have an array of tests in which it includes 2D echocardiography, NT-proBNP, and tropi levels. We try to look at that and see whether they are normal or not. Third, we also do what is known as endocrinological workup, because most of the amyloid patients will have some amount of endocrinopathies as component of it. So we look for endocrine workup. And lastly, we look at the lung functions and we look at the pulmonary function test to see whether the person has got adequate lung reserves or not. अगर ये 4-5 चीजें अगर आदमी की ठीक हैं, and the last part is bone marrow, obviously, to look at कि whether the bone marrow में plasma cell का load कितना है. अगर ये 4-5 चीजें अगर हमारी ठीक लग रही हैं, तो in that particular situation हम पेशेंट को इमीडिएटली ट्रांसप्लांट के लिए टेकअप कर लेते हैं. बट अगर इनमें से कोई भी एबनॉर्मल है, तो we then see is it reversible or irreversible, because every patient of amyloid also has some amount of reversibility of all these organ impairments. So by some sort of medications, if we can revert those, then we wait for reversing those component or elements and then take up for transplant. So this is about the transplant eligibility. Now coming to the cardiac status, yes, we are also very fussy about the cardiac status, because the maximum morbidity and the mortality in the first 100 days of the transplant occurs because of two things. One, cardiac overload. जब हम GCSF देते हैं तो amyloid protein के चलते हुए वो पानी को ज्यादा चूसता है, and GCSF and amyloid when they interact, they all retain fluid and a patient goes into fluid overload state. तो वो पानी को शरीर के अंदर ज्यादा इकट्ठा हो जाता है और उसके चलते हुए हार्ट फेलियर हो सकती है. सेकेंड, जो हम लोग मेल्फ्लान दवाई यूज करते हैं उसका एक सबसे बड़ा प्रॉब्लम होता है एरिथमिया. That means electrical abnormality of the heart. And because of amyloid, एरिथमिया के लिए हार्ट मोर प्रोन होता है. मेल्फ्लान का जो बीटा साइड इफेक्ट होता है वो भी इलेक्ट्रिकल एब्नॉर्मैलिटी होती है. तो इसके चलते हुए हमें टेंशन लगी रहती है कि भाई एमेलॉइड वाले पेशेंट में बिकॉज ऑफ द कार्डियक इश्यू, क्योंकि उसको पर से माइलोमा या प्लाज्मा सेल या कापा लैम्डा चेन के चलते हुए मॉर्टेलिटी नहीं होगी, उसके कारण उनको कोई नुकसान नहीं पहुंचेगा. सो सबसे ज्यादा नुकसान पहुंचने का कारण जो एमेलॉइड ट्रांसप्लांट्स में होता है वो है कार्डियक साइड इफेक्ट्स. तो इसीलिए हम लोग कार्डियोलॉजी की तरफ से हम क्लियरेंस और उनको ऑन बोर्ड लेके चलते हैं, एक कार्डियोलॉजिस्ट को जिनको एमेलॉइड के बारे में समझ हो, जिनको एमेलॉइड के बारे में एक्सपर्टीज हो, तो उनको हम अपने साथ लेके वी गो अहेड एंड ट्रांसप्लांट. I have done myself transplant of more than 15-16 patients of amyloid, and we have had good results because we have had good cardiologists on board along with us. So it does not mean a cardiac side effect or a cardiac problem is a no for transplant. It's just that we have to be more careful about such situations and be mentally prepared for that. Hope I have answered you, Pandya ji.
Thank you very much. Thank you very much. I am also ABMT patients, and I had done ABMT in 2019, but I am really, thanks to ABMT, I'm living my life much more better. Thank you.
Okay. Dr. Vivek, you want to add anything on this part?
No. Perfectly said, well said. And मतलब वही है कि cardiac conditions always will be in about 70% patients would be having some amount of cardiac dysfunction. So that doesn't mean that you completely rule out the eligibility until unless the patient has gone into a severe fluid overload. You wait for some time, get the fluid overload better with diuretics, get the overall situation better, and then this is always an option for the patient. Nothing much to you already covered it extensively. Very well said.
Thank you, Dr. Vivek. So we also have here on board with us Dr. Gurleen. So there were a few patients. I will share the slide from my side, slide deck. Can I have the permission for sharing, please? So there was a few questions which were prepared by the amyloid group. So it would be really nice if we can answer those questions. Yeah. So in this, Dr. Gurleen, you are there. Can you hear us? Dr. Gurleen? I see her name here. Okay. And Dr. Sumit Mirk? Okay. Dr. Gurleen is saying her audio is blocked. If we can give her the permission, please.
Yes, working on it.
In the meantime, till the time they are setting up the audio for Dr. Gurleen, any patients having any queries related to, particularly because I understand most of the patients of ours have cardiac problems associated with them, and it's really rare to have a cardiologist spare his time and come upon the platform to answer the queries. So you please type your queries in the chat box, and we will request Dr. Vivek to answer those.
Sure, sir. Pleasure.
Hello.
Yes, Ms. Navoditya.
For Madam Gurleen, she have made some changes. She have to make some changes in her own settings because this entire call is on recording, and because those people who don't want to give their permission for the recording, they can't unmute themselves. So she has to give the permission from her side.
Yeah. So Dr. Gurleen, can you do that, please?
Maybe you can log out from the meeting and join again. Then you will have that. You will find a chat that option, and you can give permission, and then you will be able to talk.
Okay, in the meantime, I think we can just go ahead. We can wait for Dr. Gulin to answer the types of amyloidosis and about genetic mutation, because she's an expert in that and she has been working on those. In the meantime, I will go ahead with the other parts. That is, how can amyloidosis deposits in organs be identified without spectrometry? Even this, I will leave it to her. Okay, how to manage organ failure and its association with other conditions like glaucoma. Okay, so when we talk of organ failure, so I'll just see if we have Dr. Rahul Bhargava or Dr. Talika Seth joining us. Otherwise, then I will take on these questions as well, just to make sure that all the questions are answered. And in the meantime, Ms. Navodita, you can also tell me if anybody from the health ministry or from the patron side have joined. We can give them a chance to speak before with the questions.
Yeah, so Dr. Atul Janwal has joined from the health ministry. So we would like him to say some words and
Yeah,
join the
sure.
discussion.
Hello, am I audible?
Yes, sir.
Yeah, okay. Myself, Dr. Atul Janwal. I am working currently as an associate professor in Department of General Medicine in Lady Harding Medical College in SSKH. So I won't be speaking much from the ministry behalf, but I'll be sharing my experience as an teacher for undergraduates and postgraduates for the past 10 years in the Delhi medical colleges. And what I would like to share is one of my experience last year only. And there was this student from the second or third year, I don't remember exactly, and he was presenting a case to me. And as these young boys and girls, they have learned these new illnesses from the these pathology textbooks and all the other books. So when the case was, if I remember correctly, it was related to some proteinuria, and the patient had some facial puffiness. So when the history was completed, I asked him what is the differential diagnosis you would like to keep. And I still remember he mentioned the first TD to be amyloidosis. And it was very rare to answer this question. And I asked him why you have answered this thing, because as a dictum in while teaching such students, young students, it is the rule that the most common illnesses should be kept as top differential diagnosis. So I asked him why you have kept. So the most obvious answer was because in the pathology it was being taught to him. And the surprising part was that when the patient was subjected to the renal biopsy and the sample was sent to GB hospital, and the lady actually had the diagnosis of this amyloidosis. And it was quite surprising, although in traditional teaching, that's the issue, that we do not usually ask the uh, students to keep such rare diagnosis as primary diagnosis. But the thing is, when these such patients who present to these tertiary medical colleges, they have been usually evaluated by the PFCs and all the local practitioner. And it is our duty to identify the rare causes. And in fact, the Harrison also mentions that the most common presentation of this amyloidosis is fatigue and unexplained weight loss. And this is the earliest symptoms which patients usually have. And these are the most often looked symptoms in the OPD, because most of the time the OPDs are very heavy, and the patients usually comes and have this complaint. And the biochemical profile of such patients will be usually normal. So it is very difficult to identify this such patients. And it has been clearly mentioned that the most of the time such patients will only be diagnosed when the end organ damage has already occurred. The organs has already involved, most commonly the nephropathy and the cardiomyopathy and the neuropathies. So by the time these patients are diagnosed, the disease has already been progressed. So what I would like to add is that, like, when we are teaching the in the as the syllabus for the undergraduates has been changed during the past few years, and the competency based medical education has been introduced, so few topics has not been made in that curriculum, and I don't think amyloidosis is a part of that curriculum. And but whenever we are discussing the cardiomyopathies and the nephropathy, this thing is often discussed with the young students. And for at this young age, from the undergraduate perspective, it is always important to remember, yes, this disease do present, and an early diagnosis is very vital. So the challenges most often faced in the government setup will be the diagnostics part, because most of the time this electrophoresis are being done only in the big medical colleges, and so most of the time these patients usually don't have these investigative modalities. And especially I'm speaking for the patients who are from the poor subset of Indian population, because those are the population which usually comes to these medical colleges. And the thing is that whenever a expensive test is being ordered, most of these patients will be lost to follow up, and they usually don't turn up, and they usually will have this terminal end stage renal disease or complete heart failure, and they usually succumb to the illness. So as an teaching faculty, I've always uh, put this thing that yes, if a patient who is coming to you in this medical college, there is a very high chances that he or she will be having something which most people will not see. And among those things, for specifically for these three illnesses, the nephropathy, cardiomyopathy, and neuropathy, I've always asked that even a single, you just have to get an abdominal fat biopsy, and rather than going for an invasive renal biopsy, just go for that. And if you find something, you can go ahead to make a diagnosis. So that's the main thing which I wanted to share, and I think most of the things have been already discussed by the respected faculty members. So that's it.
Thanks a lot. Thanks a lot, Dr. Atul, for giving your insights on that. And I totally agree with you, because I was the one of those members who have created the CBME curriculum. So we have almost 1,500 competencies. And when we
Yes,
have to choose core competencies and non-core competencies, I am from medicine department. So we need to be very choosy about what to be taught and what not
exactly,
to be
sir.
taught. But as you rightly brought out, very, very rightly brought out, whenever we are dealing with cardiomyopathies and nephropathies, so we definitely tell our patients on the bedside clinics that when you have a combination of kidney and heart, or heart and GI, or kidney and GI, please think of amyloid as a first thing, particularly when you have an organomegaly associated with it. So you have really brought it out very nicely, that as seasoned teachers, it's very important to bring about such diseases, which in true sense are not rare diseases. I would just say that they are not being diagnosed in time, as you rightly brought out, and the true prevalence of the disease in the country is very undermined or under determined. So because of which we are not able to really come out with the things. We did a study of around looking for amyloid in around 180 biopsies, which are already myeloma positive, and they were not labeled as amyloid. But when we re-looked at it, almost around 22 patients were also consequently having amyloid, which was missed in the first group. So it's very important. Simple test like fat pad biopsy or a oral biopsy or a rectal biopsy can actually rule in or rule out amyloidosis, particularly in patients who are already suffering from plasma cell dyscrasia. Thanks a lot, Dr. Atul, for your insights. But here I would like to ask on behalf of ASGI, also you have favor. Dr. Satish Chandra and his team has been really working hard to get the disease included in the rare diseases category, such that many of the patients can get a lot of benefits as soon as it gets nominated or included into the rare diseases registry or rare diseases list. So if you can help the ASGI in that particular direction, it would be really of great help.
Okay,
Thank you, sir. Thank you, sir, for supporting our cause. In fact, we had reached out to Dr. DG Sahab, DGHS, and Dr. Goel was very kind. We were supported by Dr. Vivek, and also Dr. Seth from Sandeep Seth Saab from AIMS. And there are certain policy tweaking issues that are coming in between. So if that is concluded, that is what I have been fighting, and I have been requesting the ministry. Then, sir, the cost part, the financial toxicity part will be addressed chiefly. But as you have rightly, I had shown you to at Pune last year, sir, and thereafter, because of various reasons, there are certain senior citizens, they are not able to go for autologous transplantation. But here is a case, sir. I would like to request Mr. Soumya Banerjee. Last 3 months, he has been going to different hospitals, and we are unable to get him diagnosed and treatment commenced. So in this regard, we reached out to the government and the secretary and also DGHS that if the centers of excellence, they can help us with screening, they can help us with diagnosis, they can help us with certain studies. They are having so many colleges under them. Then probably it would alleviate the situation that are faced in smaller places as well, sir. So that's what we are trying our level best. Being a patient, we all are trying our level best, and with the blessings of all of you and doctors, we are able to at least understand that this disease is really complex, but it can be addressed, sir. So I am really grateful to you for your support, and we request Image to also request the ministry in this regard.
Sure, sir. We will definitely, we are part of your campaign, and we are definitely there on your side, because we also understand so many additional. Sir, totally from Indian Myeloma Academic Group, we are part of your campaign, and we are definitely there along with you for trying to get this under the rare diseases thing. So we have our full support to you. So with this, do we also have the patron, that is Dr. Trivedi Saab on board? If so, then we can also ask his comments for his.
He informed, sir, he is busy in some religious rites, so he is unable to join. You can proceed, sir, with your moderating.
Sure. Thank you. Thanks a lot. So I would like to now take it on further to Dr. Gurleen first. And there is one question in the chat box for Dr. Vivek. So first to Dr. Gurleen. Dr. Gurleen, there are some set of questions that people have for you. So can you join, please? Can you come on board?
Yes. Good evening, everyone.
Yeah.
Sorry.
So I will like to introduce you once again to the people. So Dr. Gurleen happens to be the chief person from Indian Myeloma Academic Group for the amyloid chapter. So she is working hard to put the things together in the country from the doctor's side, and to get some homogeneity in the management and other things. So we are also planning to come up with guidelines. This was one of the requests that ASGI had towards us, that the treatment was heterogeneous across the country. So we are trying to bring things put together. We are trying to stitch together things. So Dr. Gurleen, who happens to be a DM in hematopathology from AIMS New Delhi, and currently practicing as the senior consultant in Medanta Group in the hematopathology, and previously she was a senior consultant and the head of the reference laboratory at Lal Path Labs. So welcome, Dr. Gurleen. Dr. Gurleen, can you the genetic mutations and the diagnosis of amyloid for the benefit of the patients?
Yeah, so most common mutations or genetic mutations which we get are mostly related with the hereditary familial amyloidosis, which we know which exists, which involves commonly the heart and causes the polyneuropathy and all. So the common ones are TTR, that is transthyretin mutation, apart from that fibrogen, gelsolin, ApoA1, A2, all these can be mutated. However, in the diagnostics of the amyloidosis, as it is rightly pointed out, it is a hassle because the patient presents with different non-specific symptoms and presents to different departments, thus having different protocols leading to the delay in the diagnosis, and because of the different protocols which the different clinicians follow for the diagnosis. And sometimes the symptoms are so non-specific that there is a delay in pinpointing the amyloidosis. But once that starts, the first thing which is difficult in amyloidosis is because amyloidosis needs biopsy, and the biopsy specificity also relies on the multiple site, and the multiple site biopsies are required. That is one of the issue. And apart from that, once the biopsy is also done, there's a patchy involvement even in the bone marrow, like which is commonly done in so multiple site biopsies are required for a higher sensitivity of sensitivity, so that we are not missing the patients which are suspected for amyloidosis. So first the biopsy part. Once the biopsy comes, then when you see in the biopsy these amyloid actually appears as amorphous acellular pink material, and which can mimic collagen, which can mimic multiple things. So we have to correlate with the clinical profile. We have to have a high suspicion, and the further course of action is to go for a Congo red staining. So Congo red staining is then put on the biopsies, and on the Congo red staining, on immunofluorescence, it gives apple green refringence, which is quite sensitive for defining amyloidosis on these biopsies. And so once the biopsy gives the answer that the patient is having amyloid, the second thing is much more important, is to type it. So the typing of the amyloidosis is a challenge in our setup in India, because most of the places are stopping at diagnosing it. Even when we were collecting the research work, most of the research work is till diagnosis, or at the most they go for IHC. So the IHC part is the next part. The most common typing strategy which is being used is IHC, and for primary amyloidosis, in which kappa and lambda are put, but the specificity is quite low. It is around less than 50%. So for primary amyloidosis, IHC is still less sensitive. In renal amyloidosis, immunofluorescence is a good strategy which we go for, but again, it is for that the processing and everything changes the tissue for the diagnosis a lot. So sometimes the pre-processing artifact or pre-processing diagnostic parameters play a role at the time of diagnosis as well. So first is IHC, the second is immunofluorescence. The third strategy is immunoelectron microscopy, in which the gold labeled antibodies we use for typing these amyloids. So, but this is quite rare, and it is being used in very less centers in India. So we are then left with, and we have to now put all our efforts to develop proteomics, that is mass spectrometry, to diagnose and type it, and it should be the way forward, is what I think.
Thank you, Gurleen, for elaborating on that. So just few points of what you conveyed for the benefit of the patients I'd like to reiterate. जो एक मैडम ने बहुत important point जो बताया है, patchy involvement. So many patients come to us and say कि सर वो बायोप्सी पहले अस्पताल में हुआ था, वहां नेगेटिव था, फिर से बायोप्सी हुआ दूसरे अस्पताल में पॉजिटिव आ गया. So पहला अस्पताल अच्छा नहीं था. So it's not about पहला अस्पताल या पहला डॉक्टर साहब. It is about the fact that because of the patchy involvement, जब मैंने पहली बार सुई डाली है, if I was the same doctor at both the events, if I put a needle in the first go, have I touched the right part or not? जहां बीमारी affected है, उसको मैं needle कर पाया हूं या नहीं कर पाया हूं. So मैडम ने जो बहुत एक important point बोला है, that is about multiple biopsies or repeated biopsies. So many a times, even in patients with amyloid, it is not that in the first go itself, the diagnosis is achieved despite of getting a tissue biopsy. Sometimes in some patients, they might have to undergo the procedure twice or thrice. Now patient की तरफ से आपको बड़ा बुरा लगता है, एक बीमारी पता करने के लिए इतनी बार क्या ढूंढना है, बट ये बीमारी इतनी पैकिंग होती है, बराबर हर जगह फैला हुआ नहीं होता है. So we might miss in certain situations. So that is the first component which I wanted to tell. Now second, she very beautifully brought out कि देखो डिफरेंट ऑर्गन बायोप्सीज की सेंसिटिविटी और स्पेसिफिसिटी अलग होती है. अगर किडनी की बायोप्सी हो तो उसमें पिक करना थोड़ा ज्यादा आसान होता है. यही अगर बोन मैरो पे केवल मैं एमॉर्फस मटेरियल देख रहा हूं तो उस पे मुझे मतलब ना ये एमिलॉइड है या नहीं है या कुछ और बीमारी तो नहीं है ढूंढना थोड़ा ज्यादा मुश्किल होता है. सो हर एक इट डिपेंड्स कि किस पेशेंट का किस अंग का बायोप्सी हुआ है. एंड if it is an endomyocardial biopsy, uski sensitivity specificity alag hoti hai. So it's not the same across different organs and different ways. So people also need to understand that depending upon kaun se organ ka involvement hai ya kaun se organ biopsy hua hai, usse picking up the disease is different. Now the last point which madam very categorically said is clinical correlation. अब बायोप्सी में हमें कुछ नजर आ रहा है, वो कई चीजें हो सकती हैं. It is not mandatorily that it has to be only amyloid. So a clinical correlation, a good crosstalk with a clinician and a pathologist and a clinician coming together and trying to talk it out कि ये क्या हो सकता है, क्या-क्या differentials हो सकती हैं, उससे बहुत ज़्यादा फर्क पड़ता है. So all these things put together, we have to understand in our country, the diagnosis of amyloidosis is still not very forthcoming, or it's not one of those diagnoses जो ऐसे ही पता कर लिया और हमें immediately पता चल गया है. इसमें थोड़ी मेहनत जरूर लगती है and शायद एक अटेम्प्ट नहीं 2-3 अटेम्प्ट्स में जाके बीमारी पता चलती है. Because all the patients I have around a summary of around 62 patients of amyloid with me. Let me guarantee you, इनमें से शायद एक पेशेंट था जिसका मतलब upfront diagnosis मिला था, but most of the मतलब like I mean to say pathological diagnosis. Clinically we were suspecting कि उसको amyloid है, but उसको पैथोलॉजिकली प्रूव करने में शायद एक ही पेशेंट था जिसका इमीडिएटली पता चला. बाकी सारे पेशेंट्स में हमें थोड़ी मेहनत लगी और थोड़ा टाइम लगा फ्रॉम द पॉइंट वेयर वी सस्पेक्टेड कि इसका एमिलॉइड है तब से लेके एमिलॉइड को प्रूव करने में. और इस 62 में से ऐसे करीब 10-12 पेशेंट आज की तारीख में भी है जिनका अभी तक हमें टिश्यू डायग्नोसिस नहीं मिला, केवल क्लिनिकल डायग्नोसिस के बेसिस पर हम उसका इलाज कर रहे हैं. तो ये भी होता है. सो दिस इज जस्ट टू पुट द थिंग्स टुगेदर. नाउ डॉक्टर गुरलीन, आई ऑल्सो वांट टू आस्क यू अबाउट मास स्पेक्ट्रोमेट्री. Where are we in the country and what is the way ahead?
So in mass spectrometry, we have just started. The thing is, one of the study which was done by Dr. Nikita Mehra, I came across. She tried and she diagnosed the amyloidosis or not type it, but to identify the M protein on the on mass spectrometry by using a modified method which was used in Mayo Clinic. She came up with something which was cheaper and which can be implemented in our country for mass spectrometry. So that is one thing which was prominent when we were seeing what all has been done in amyloidosis. The second thing is eProteomics is one of the company which is prominently doing the work and is being collaborating with Lalpath Lab for mass spectrometry of all the amyloid cases. So and mass spectrometry is in itself now starting to come in diagnostics, but the typing part it's still very I would say it's still beginning to happen. It's not started yet.
Yeah, totally your point is taken. So we are way ahead. We are like, we need a lot more in this field for coming to the actual bedside medicine, and it's in its infancy as far as the mass spec in our country is concerned. But the good news is there are two companies. Sebia is coming up. It's a company which is coming up as mass spec in our country. There is another company which is a diazyme based thing which is also trying to venture into mass spectrometry in our country. And as rightly brought out, not only Nikita, she's from the Chennai Adiyar Cancer Institute. We also have people from both Pune group and in Delhi group who are working on mass spec. In fact, Dr. Rahul Bhaga, if he would have been here, I would have been very happy, because he has been working, his group has been working on the mass specs, and they have recently installed the equipment for mass spectrometry in their institute at Fortis. So we have some groups which are working on it. But yes, as Dr. Gullin rightly brought up, we still are not yet there. It might take slightly some more time for us to reach that particular part. Okay, getting back to the questions in the chat box. Thank you, Dr. Gullin. Yes, Mr. Atul, I'll just come back to you. So I'll just answer first. I would request the answer from Dr. Vivek on a question by Madam Shriya. So Dr. Vivek, there is a question in the chat box, which is for you, which talks about my father had a transplant in October 22. His GLS was minus 9.5. I think, yeah. Earlier, they were saying he's having renal amyloid, but before SCT, they did 2D echo, and at that time, they were saying cherry on top. What is this? So he had just explained cherry on top is one of the clinical manifestations on echo, which is characteristic of amyloid. But I would request Dr. Vivek to answer this query in the chat box on cardiac amyloid, please.
No, so if I can gather it correctly, the question is basically about the importance of the cherry on top or the GLS scoring, or what is it? Sorry, I couldn't get the initial part.
I think it is purely about what is cherry on top.
Okay, so it has been found for some unknown reasons that in involvement of the cardiac myocardial structure, the bases are involved more. So the heart, if you visualize it as a bullet, there is a base and then it tapers to the pointed end. The pointed ends or the apex or that portion of the heart is spared till the last. So when we do a global longitudinal strain imaging, that imaging basically shows what the amount of involvement of the disease is, and it shows us a pattern which is color coded. So if the heart pumping is completely normal, it will appear as a bright red. And if it will lose its shade, become pinkish if the heart muscle is not as effectively doing its work as it should. And if it completely gets damaged, it goes into shades of blue. So when we do this GLS, the color coded structure which comes out as a form of a bullseye. And the bullseye involvement has got spherical lines. So classically, amyloid will show that the periphery or the bases of the heart are either very light pink, because that has been involved the worst. And as we proceed upwards to the apex of the heart, that the contractility and the systolic functions and everything is as normal as it of any other person. So the color code will appear as if the whole thing is in shades of pink, and as we go upwards, it becomes red. Red as in, if you put a cherry on top of a cake, which is pinkish in color, the tip of that cake appears red and bright and fluorescent. So this is what we see on the global longitudinal strain. And this is characteristic of amyloid, although there are certain other situations where it is reported. So it is a sensitive but not a very specific marker. So when you say that there is a cherry on top, automatically it is one of the biggest red flags. But then I must add to this that it is not 100% pathognomic sign of amyloid only. It has been found in our practice as well as in other parts of the world that it can be mimicked. So doesn't mean that since there is a cherry on top on GLS, it is 100% pathognomic. It is a very strong pointer that we should proceed towards further tests to confirm amyloid. But again, that is not to be taken as 100% amyloid. Sir.
Thank you, Dr. Vivek. Dr. Vivek, can you also answer this question on the screen? That is, how to manage hypertension, particularly with amyloid and heart muscle weakness progressing?
Hypertension. Okay. So usually these patients do not have hypertension as its presentation. It's rare to find hypertension because, as I had explained earlier, the heart is getting underfilled. So since it is a stiff heart, you need an elastic recoil from the heart to relax first and then contract. Since the amyloid makes the heart tissue very stiff, so then it does not fill to its capacity. That means less amount of blood can get accumulated in the stiff heart. If it was a spongy muscular heart as it should be normally, it expands as the blood pours into it. But then as it becomes stiff with deposition of amyloid, it cannot take in amount of blood which is usually normal for another human being. So this is why it is called a restrictive cardiomyopathy or restrictive filling pattern. So once the volume of blood entering the heart is low, the amount of blood leaving the heart is also bound to be low. So this is called a stroke volume or a cardiac output. Cardiac output or a stroke volume is a major determinant to decide the blood pressure of a person. So if the amount of blood leaving the heart is less, the blood pressure that is being generated is usually on the lower side. So it's rare to find an amyloid heart patient having hypertension. But if rarely it is there, diuretics, the ones which are meant to increase the urine output, are the mainstay of hypertension involvement also. But in my experience on amyloid, I'm yet to find a single patient of amyloid, a significant amyloid. Hypertension can be present in the initial phases, and one of the red flags, in fact, for physicians who may be attending this is that if you know that a person is having high blood pressure, and gradually you are following that patient, and amongst the other symptoms is heart problem, that is breathlessness, which is non-specific. If the blood pressure starts lowering by itself, so that now you have to remove those blood pressure reducing drugs, and even then the blood pressure remains low without any specific dehydration or any loss of volume, this is one of the red flags that this patient is having now an underfilled heart and amyloid heart disease. So lowering of requirement of blood pressure drugs to a level that even without the blood pressure medication, lowering medication, the blood pressure continues to remain low in a person who first had a high blood pressure is one of the red flags, a very prominent and characteristic red flags of amyloid heart disease. Sir.
Thank you, Dr. Vivek, on that. So you have very beautifully explained when will the patients develop hypertension, and for patients with hypertension, they're not requiring antihypertensives. Just a point, because I've seen and two hypertensive episode for postural fall. So also, other than the cardiac, if the cardiac evaluation is normal, we also need to look for autonomic nervous system या ANS involvement जो हम बताते हैं, वो भी देखना बहुत जरूरी है. Thank you, Dr. Vivek, on that. I'll go to the next question. Nitin Jain ji ने एक क्वेश्चन पूछा है, what is the standard period of maintenance after transplant? If a patient completed 2 years of maintenance after transplant in complete remission, should he continue his maintenance or stop it? So Nitin Jain ji, let me answer this question very categorically. As far as the practice is concerned, the guidelines are concerned, there are two different things. Guidelines कहती हैं कि maintenance तब तक देना चाहिए जब तक relapse ना हो जाए. But most of the hematologists on today's date, though it's not in books, but we look for remission status and MRD evaluation करते हैं with the help of hematopathologists. और अगर MRD negative है, MRD का मतलब होता है minimal residual disease, जिसको हम flow cytometry से करते हैं, और अगर वो लगातार 2 बार नेगेटिव हुआ एक पेशेंट को 2 साल के बाद 6 महीने के गैप पे, तो उन लोगों को हम लोग दवाई बंद करके वेट करते हैं. बिकॉज जितनी भी हम दवाइयां देते हैं, वेदर इट इज बॉटिजोमेब और लेनालिडामाइड जो हम मेंटेनेंस के तौर पे देते हैं, उनकी खुद की साइड इफेक्ट्स भी बहुत सारी अपने आप में होती है. एंड मोस्ट इंपॉर्टेंटली हिंदुस्तान में सबसे बड़ी प्रॉब्लम है कॉस्ट. सो अगर हम नॉन स्टॉप मेंटेनेंस देते रहे पेशेंट को, तो उसका जो एडेड कॉस्ट होता है तो वो भी बहुत ज्यादा हो जाता है ओवर अ पीरियड ऑफ टाइम. सो कंसिडरिंग दोज पॉइंट्स, इट इज physician to physician, it differs, but there are few physicians who stop it at 2 years if the patient is in MRD negativity state. But अगर हम केवल गाइडलाइंस या कागजों के हिसाब से जाया जाए, तो आज के तारीख में पूरे दुनिया की गाइडलाइंस ये कहती हैं कि आपको मेंटेनेंस तब तक देते रहना है जब तक पेशेंट वापस उसकी बीमारी वापस ना आ जाए. So these are the two views about it. So that's as far as the answer to Nitin Jain ji is concerned. Now, coming to the next question, with Atul Pandya ji has asked, after completing ABMT, again after a few years, FLC and ratio became abnormal, intense severity of disease, can we go for second transplant? Okay, so agar if the rise in FLC ratio has occurred to pathognomic levels, pathological levels within 2 years, तो फिर ट्रांसप्लांट का दूसरी बार करके फायदा नहीं होता, क्योंकि अगर वो ट्रांसप्लांट का फायदा होना था तो ट्रांसप्लांट एक आदमी को तकरीबन 2 साल तक तो मिनिमम इट विल कीप अ पर्सन अंडर रेमिशन स्टेट. बट अगर पेशेंट के एफएलसी रेशियो 2 साल के बाद बढ़ रहा है तो यस डेफिनेटली देयर इज अ रोल ऑफ डूइंग अ ट्रांसप्लांट. नाउ अब कई लोग ये 2 साल का, सम गाइडलाइंस से 5 years, some guidelines say 1 year, but जो on an average across the world the number which is agreed to is approximately 2 years तक अगर आदमी रेमिशन में हो और उसके बाद अगर उसकी बीमारी बड़ी है तो then in such situations we take it up for a second transplant after the 2 years time. The next question is from Soumya Banerjee ji. Main problem of patient is not more hungry and also weakness. Okay, hungriness like भूख न लगना एक अलग चीज है, भूख लग के जल्दी पेट भर जाना अलग चीज है. एमेलॉइड में दोनों चीजें होती हैं. जिन लोगों को गट का एमेलॉइड होता है, दैट मींस माउथ से लेके एनस तक, अगर जीआई ट्रैक्ट जो अपनी आखड़ियां होती है अगर वो इन्वॉल्व होती है एमेलॉइड से तो भूख नहीं लगता है. बट जिसकी तिल्ली बड़ी होती है, द स्प्लीन, जिन लोगों की, उन लोगों में भूख जरूर लगती है लेकिन उनको जल्दी भूख, मतलब जैसे वो कुछ एक रोटी खा लिया पेट भर जाता है. सो दोनों के इलाज अलग अलग हैं. जो तिल्ली के कारण है उसमें अगर हम तिल्ली को हटा दें, स्प्लीनेक्टमी कर दें या इलाज करें जिससे कि स्प्लीन साइज कम हो जाए तो भूख जो लग रही है आदमी पेट भर के खाना खा सकता है. जो दूसरी प्रॉब्लम है जिसमें गट इन्वॉल्व है उसका इलाज थोड़ा सा मुश्किल है, क्योंकि जैसे वो एक ऑर्गन है, वो ऑर्गन ऑलरेडी डैमेज है, इन्वॉल्व हो चुका है, तो भूख वापस आना आई एम नॉट रियली श्योर कितना पूरी तरह से हो पाएगा. बट यस, इन सच पेशेंट्स it's one of the indication for taking such patients for transplant because it's considered as one of the organ damage per se. So that's as far as the hunger is concerned. Now next question is from Soham Gosal जी. आपका क्वेश्चन ये था, patient is having loss of appetite and dizziness and also suffering from dyspnea. So loss of appetite, GI tract, आखड़ियों का इन्वॉल्वमेंट, डिजीनेस जैसे हमने बोला वो ऑटोनॉमिक नर्वस सिस्टम के कारण भी हो सकता है, हार्ट के इन्वॉल्वमेंट के कारण भी हो सकता है, और अगर डिस्निया है तो हार्ट का इन्वॉल्वमेंट पक्का है उस पेशेंट में. सो पुटिंग ऑल ऑफ देम टुगेदर अ पेशेंट इज हैविंग मल्टीपल ऑर्गन इन्वॉल्वमेंट एंड सच पेशेंट्स डेफिनेटली नीड देयर एफएलसी रेशियो टू बी कंट्रोल्ड और वेल इन टाइम, पुट इन टाइम थिंग. एंड अगर उसका ट्रांसप्लांट के लिए एलिजिबिलिटी है तो दे शुड बी टेकन अप फॉर ट्रांसप्लांट. अतुल पांड्या जी ने नेक्स्ट क्वेश्चन पूछा है, मास स्पेक्ट्रोमेट्री कैन इट रिप्लेस द एसएपी टेस्ट done by NAC or Royal Free Test? Okay, you are talking about serum amyloid protein, which is used for tagging. I will leave it to Dr. Gurleen to answer this. She's on board here. So can Dr. Gurleen answer this question?
So it is one of the promising modalities, SAP test, which is considered because of its high specificity for amyloidosis. So definitely SAP test is one of the tests which can be considered in the future, but in comparison, we don't know yet because it has not been studied or the data is not there to know whether it can completely replace the mass spectrometry, because of the reason that it is done in very few and occasional places in the world.
Wonderful, Dr. Gurleen. I think you have summed it up very well. So both mass spectrometry and SAP, both of them are investigational in as far as India is concerned. There is one center in our country which is trying to work up with the NHS hospital to come up with SAP in Indian scenarios also. So only thing which needs to be understood is SAP का बहुत ज़्यादा benefit ये होने वाला है. There are some drugs which are coming up which will affect or which will target SAP. So it's an anti-opsonin protein. So अगर वो दवाई बन गई तो हम ये देख सकते हैं कि जो भी SAP पॉजिटिव होगा उस पेशेंट में ये दवाई का असर जरूर होगा. So people are working on that angle. Now, using it for diagnostic and prognostic purposes, SAP is under evaluation for that. It's being used both for diagnosis and for prognostic purposes. And people say with treatment, if the SAP levels are falling, so the patient is considered as getting treated or cured. But again, as Dr. Gurlin rightly brought out, they are all still in research mode, bringing them to bedside mode. Though I understand UK hospitals are using SAP regularly, particularly Dr. Vachlekar's group, and we have also Dr. Karthik who is working there. They are working on it, but I'm not really sure that if it is used across the world. Atul Pandya ji ne aur ek question pucha. On the day of chemo, due to DEXA, blood pressure is observed very high. Need to manage by BP medication. It's a regular phenomena. So yes, steroids lead to rise in blood pressure. But again, we have Dr. Vivek here, so I will redirect this question to Dr. Vivek, if he can comment on it. So as part of chemotherapy, we give Dr. Vivek dexamethasone in some patients on a weekly basis, and in some patients at least on a twice weekly or a fortnightly basis. So and DEXA leading to high blood pressure is often known. So your take on how to manage a BP medication for those who have steroid-induced hypertension?
So not specifically for steroids per se, but in any such patients, first and foremost is we can increase the dose of diuretics. The diuretics are going to not only bring the blood pressure down, but they are also going to also reduce the other symptoms of dyspnea and fluid overload and the HFpEF, the preserved ejection fraction heart failure that we see in such patients. Mostly we are restricted in our use of diuretics because of blood pressure. Normally, if the blood pressure allows us, then we can increase the dosage of diuretics to a stage where the symptoms starts getting, the swelling in the feet, the breathlessness start improving. So even during these phases of rise in blood pressure with any drug, especially the steroids, I think diuretics doses can be increased and they'll serve a dual purpose to our advantage. Obviously, the second group that is basically the calcium channel blockers. The ACE inhibitors and ARBs and ARNIs are sort of contraindicated because not exactly contraindicated. They have to be, certain societies say, used with extreme caution. हम 2B कहते हैं कि बहुत extreme caution से use करें, सिर्फ एक आध दिन के लिए जब हो. But otherwise, calcium channel blockers can be a second stage thing. उसके साथ अगर धड़कन बहुत तेज है, नॉर्मली हम बीटा ब्लॉकर्स का ग्रुप नहीं देते हैं, बट अगर कोई धड़कन भी बहुत तेज है तो वो बीटा ब्लॉकर्स भी दे सकते हैं. और लास्ट में जो कि डिजीज अपने इनहेरेंट अमाइलॉइड डिजीज को भी और ब्लड प्रेशर को भी टारगेट करता है, वो है जिसको कहते हैं स्पाइरोनोलैक्टोन या एल्डेक्टोन के नाम से आता है. उससे भी वो एक थर्ड लाइन ड्रग फॉर ब्लड प्रेशर कंट्रोल है दुनिया भर में, वैसे भी बगैर अमाइलॉइड के. और ये एक ऐसा ड्रग है जो अमाइलॉइड में थोड़ा बहुत फायदा पाया गया है और अब उसके अभी इंडिकेशंस आ रहे हैं डिफरेंट यूके एंड अदर सोसाइटीज में. सो डायरेटिक्स, एम्लोडिपिन एंड रेयरली बीटा ब्लॉकर्स और लास्ट में स्पाइरोनोलैक्टोन. ये हमारे पास ड्रग्स हैं जो कि हम ब्लड प्रेशर को लोअर कर सकते हैं.
Thank you,
very much,
Dr.
Doctor.
Vivek. Yeah, thank you, Dr. Vivek. So coming to the next query, which is by Satish Chandraji, the founder of ASGI. He has asked specifically to me about the use of CAR-T therapy, including teclistamab in India, and can it be approved as orphan drug clinical trial status? So let me first confirm to you, as far as CAR-T and teclistamab are concerned, still, even in US, they have not yet been approved for amyloidosis. There are studies going on wherein people have done multiple clinical trials in US on use of CAR-T. Now, anti-BCMA CAR-T, even for myeloma, is not available in India. The trials are started just this year, wherein there was first paper which was published in ASH this year, wherein there was an experience of 6 patients. The paper was led by Hari Menon sir from St. John's, wherein they have published their experience of 6 patients. Next year, we are going to have 2 major trials of anti-BCMA CAR-T in India for myeloma. So the step 1 is to prove it that it helps in myeloma in Indian patients. Then comes the next stage of the other affiliated plasma cell dyscrasias like amyloidosis. So that's as far as CAR-T is concerned. So I don't see it anywhere before a year and a half in India for trials, clinical trials of CAR-T in amyloid. Now, the second part is teclistamab. Teclistamab is currently available in open market in India. So teclistamab, जैसे कोई भी नई दवाई आती है इंडिया के अंदर, so the DGHS and the CDSCO, they give approval for specific conditions. On today's date, teclistamab is only approved for relapsed refractory multiple myeloma with 3 lines refractoriness, जहां पे पेशेंट को इमिड मिल चुका होना चाहिए, बॉटिज्म मिल चुका होना चाहिए, एंड पेशेंट्स को एक डाराटुमुमैब मिल चुका होना चाहिए, उसी को टेक्लिस्टमैब माइलोमा के लिए इलाज कर सकते हैं. Now, internationally also, there is only one paper of forward for God, who have published their series on use of teclistamab in relapsed refractory amyloidosis. उन्होंने भी वहां पे ये बोला है कि बाकी अगर सारी exhaust हो गई तो this is a good option available. This was published in last year ASH, not this year. Last year के ASH में publish हुआ था ये. So उन लोगों ने उसमें बोला था कि मतलब ना teclistamab can be used. So in India, definitely yes, it's one drug which we can try. We can talk to J&J people and ask them to conduct trials on amyloid patients, because हमारे पास बहुत बड़ा subset है amyloid का. All put together in the country, we have got around 500-600 patients of amyloid as of now, which we know of. There must be many more which we don't know. So we can ask J&J to conduct some trials on that. But as of now, the clinical trial status for both the drugs is not available. Now, asking it as an orphan drug, that can only be done once we have shown efficacy and safety, most importantly. So, वो एक बार अगर prove हो जाए तो उसके बाद. Now, problem क्या होता है कि teclistamab जब भी हम लगाते हैं तो उसका on target off label problems होती हैं. Parkinson's, ICANS, that is neurological toxicity, and CRS. Amyloid अपने आप में neurological complications करता है, and cytokine release is much more in amyloid patients with teclistamab. तो इसकी safety कितनी होगी? That needs to be learned or seen in Indian patients. So it's something which we can work upon. So, but yes, that's as of now, it's too far away from having it as a clinical trial drug. Yeah, सौम्या बनर्जी जी, आप कुछ पूछना चाहते हैं, बताइए. सौम्या बनर्जी जी, हाँ, प्लीज गो अहेड.
हाँ सर, मेरा पिताजी का अभी तक वो डिजीज पकड़ में नहीं आया है, तो उनके लिए मैं भी थोड़ा परेशान में हूँ. तो अभी तक आपका बोन मैरो बायोप्सी भी हुआ था, उसमें कॉन्गो रेड स्टेन नेगेटिव आया था. रेक्टम बायोप्सी भी हुआ था, वो भी नेगेटिव आया था. फिर डॉक्टर ने सजेस्ट कर रहे हैं एब्डोमिनल फैट बायोप्सी, जो हम लोग चेन्नई में करवाया था, ऊपर से चेन्नई अपोलो में. तो चेन्नई से हम कोलकाता आ गए. अभी हम टाटा मेडिकल सेंटर से जुड़ा हुआ है. टाटा मेडिकल सेंटर फैट बायोप्सी छोड़ के वो रेनल बायोप्सी करना चाहता है. तो रेनल बायोप्सी नेगेटिव, देन फैट बायोप्सी के लिए वो आगे बढ़ेगा. तो पिताजी का हालात इतना अच्छा नहीं है, इतना बायोप्सी वो कर पाएंगे. तो इसके लिए क्या सॉल्यूशन अदर कुछ है क्या सर?
सौम्या बनर्जी जी, मैंने आपने जो इवन चैट बॉक्स में भी लिखा था उसका भी मैंने पढ़ा है. एनीवे, टाटा मेडिकल सेंटर में कौन देख रहे हैं, कौन से डॉक्टर साहब देख रहे हैं आपके पेशेंट को?
डॉक्टर रीना नायर दिख रहा है.
वंडरफुल. मैं मैम से, रीना मैम से बात कर लेता हूँ. मैडम आज तक छुट्टी पे है, मैडम मंडे से ज्वाइन कर रही हैं वापस. बट जो मैडम का कहना है एज फार एज किडनी बायोप्सी, थोड़ी देर पहले डॉक्टर गुरलीन मैडम ने भी आपको समझाया था, किडनी में एमिलॉइड ढूंढना ज्यादा आसान होता है when compared to other organs. Though gut biopsy or rectal biopsy is very good for picking it up. अगर rectal biopsy negative है and particularly आपने लिखा है कि kidney function normal है, तो kidney function normal होते हुए वो लोग kidney biopsy करना चाहते हैं. तो इसके बारे में let me talk to madam on this, because there are certain questions which are very patient specific. So वो जो treating doctor होता है उनके दिमाग में ऐसा कुछ होता है जो आप हमें नहीं बता पा रहे हैं. सो जरूर मैं आपके बारे में, इनफैक्ट आप इसके बाद सतीश चंद्रा जी के पास मेरा नंबर है, मैं इवन ग्रुप पे भी हूँ, आप मुझे अलग से मैसेज कर दीजिए, मैं मैम से, रीना मैम से आपकी अलग बात करवा दूंगा. ओके, मंडे का या ट्यूसडे को, एंड देन वी कैन टेक ए कॉल ऑन योर केस. ओके, ठीक है सर, ठीक है.
ओनली सिम्टम है सर एंटीप्रो बीएनपी हाई है 12,483 और यूरिन 24 आवर्स यूरिन प्रोटीन है 237.
That's what I'm saying. See, many a times what happens is it's a very part information. जो मतलब like even as a doctor also, any one of us, whether it is Dr. Vivek जो अभी हमारे साथ हैं या Dr. गुरलीन, मैं पार्ट इंफॉर्मेशन के साथ नहीं. वी नीड टू सिट विद द पेशेंट. एक एमिलॉइड पेशेंट के ऊपर आधे घंटे से 45 मिनट मिनिमम लगते हैं समझने के लिए कि उनको क्या क्या तकलीफ हो रही है. जैसे सतीश चंद्रा जी मेरे पास आए थे, मुझे तो 24 घंटे लगे. मैंने उनके सारे डॉक्यूमेंट्स अपने पास ले लिए, मैंने उन सबको बैठ के करीब 4 घंटे पे मैंने उनकी समरी बनाई, एंड देन आई गिव इट बैक टू हिम. So it's very difficult to answer like this on a Zoom call or a Google Meet. But yes, what our aim is to help you out. तो उसके लिए we can have a separate discussion with Reena madam on board, and because she is the treating doctor, so madam will be able to answer your queries better.
Yes, sir. Thank you.
Yeah, I will take up the last question because it's already 9:20. So I will take up the last question from Shriyaji. She has asked, my father mainly having renal amyloidosis and his FLC were constantly falling and the ratio is normal. He never had M-band, but there's no, and after 2 years after the transplant, the FLC number has started to rise. And ratio is normal. There is no new thing, suspicious faint band noted in gamma region. But doctor says normal ratio, nothing to worry. So should we ignore this faint band? What happens is, Shriyaji, it's a very, very good question that you have asked. So first thing first, ratio jab tak normal hai. See, a rise in FLC numbers can occur in a patient with kidney dysfunction. अगर हल्का सा किडनी यूरिया क्रिएटिन बढ़ रहा है तो एफएलसी नंबर भी बढ़ेगा, बट जब तक कापा और लैम्डा के रेशियो में प्रोपोर्शनेटली बढ़ रहे हैं तो तब तक हमें घबराने की बात नहीं होती है. सो एज फार एज द एफएलसी रेशियो नॉट राइजिंग is perfectly okay even with individual kappa and lambda numbers being rising. The second point you brought out is पहले कोई M-band नहीं था, अभी faint M-band है. So we call it something known as the immune reconstitution stage. So हर एक आदमी जो autologous transplant करवाता है, they go into a status known as immune reconstitution, जहाँ पे एक हल्का सा M-band transplant के बाद नजर आ सकता है. It is very important to understand ये immune reconstitution है या ये बीमारी बढ़ रही है. सो अगर एफएलसी रेशियो नॉर्मल है, अगर ऑर्गन फंक्शंस नॉर्मल है, जितने भी ऑर्गन्स हैं उनसे जो पहले अफेक्टेड ऑर्गन्स थे उनके फंक्शंस नॉर्मल है. मान लो अगर पहले कार्डियक इन्वॉल्व था तो पहले एंटी प्रो बीएनपी जो था वो अभी नॉर्मल लेवल पे चल रहा है, इको नॉर्मल पे है. अगर पहले गट के प्रॉब्लम्स थे तो अभी गट के प्रॉब्लम्स नहीं है. तो अगर ऑर्गन की सिम्टम्स नहीं, न्यू डेवलपमेंट्स नहीं हुई है, just based on a faint M-band, we need not worry as long as the FLC ratio is normal. But yes, it definitely calls for close monitoring to be sure that this is immune reconstitution. अगर हम 3 महीने पे अगर 2-3 बार चेक कर लें and हर बार उतना ही आ रहा है, then you can just forget it and don't worry about it. But yes, on a close monitoring, if you are seeing it is gradually rising with every 3 months, then yes, you need to talk to your doctor and get the further evaluation on it. But I agree with the doctor on the part, जब तक ratio normal है, we really are not worried much about it. Yeah, FLC numbers can fluctuate as I was saying. It is a kidney function base पे FLC के numbers ऊपर नीचे होते रहते हैं. तो क्रिएटिनिन बढ़ा, FLC number भी बढ़ेगा. क्रिएटिनिन कम हुआ अगली बार में तो FLC number भी कम हो जाएंगे. तो it is a ratio. Individual numbers को हम नहीं देखते हैं. We only go by ratio. And when you say what is immune reconstitution, जैसे ही आदमी कोई ट्रांसप्लांट करवाता है तो उसके बाद थोड़ी प्लाज्मा सेल्स होती हैं जो शरीर के अंदर एक्टिवेट होती है और वो हल्का अमाउंट ऑफ प्लाज्मा प्रोटीन प्रोड्यूस करती है. ये प्लाज्मा प्रोटीन अपने आप में बीमारी नहीं है एंड ये उतना ही कांस्टेंट रहेगा. लाइक सो एक आदमी का 0.3 ग्राम या 0.4 ग्राम है, अगर मान लो एम स्पाइक, वो उतना ही मेंटेन रहेगा अगले 2-3 सालों तक. तो उसको इम्यून रिकॉन्स्टिट्यूशन बोला जाता है. So it's a phenomena which occurs after the autologous transplant. So it occurs in around 10% of the patients. So अगर M spike नहीं बढ़ रहा है and वो constantly उतना है, then we don't need to act on it. That's what is meant by immune reconstitution. So now it's 9:20. So I hand over the stage back to Miss Navodita for the remarks from the group and from Satish Chandraji.
Sir, I am grateful to you, sir, that you have so nicely explained. And last year, sir, I had met you as a patient, and after that, the first World Amyloidosis Day last year, I still remember Dr. Pankaj Malhotra sahab had told me that you are obsessed with it. Actually, sir, we are a researcher, but we do not have proper perception of the medical terminologies. So we struggle with the Google University or here and there, whatever we try to get information and exchange amongst ourselves. Now, sir, once you have established the amyloidosis clinic and you have dedicated such experienced doctors working on that, we have 18 patients. If they give their number or they share their email, sir, we will share the questionnaire to them. Then probably we will be obliged that out of 500 patients, if those 18 patients which we are in the group and we are trying to expand it, and we are pleased to also share, sir, that Bihar chapter led by Dr. Avinash from EMS, a student of Dr. Tulika madam, and also a student of Dr. Rahul Nathani Sahab. He's working there. About West Bengal chapter, sir, we have got 3-4 patients, and Navodita madam is also from West Bengal. She is our event management partner, very closely working with Jha Sahab. So we have a kind of situation we have created. In government, sir, we are speaking with different channels, and I will meet Jonwal Sahab if his students can be drafted for certain studies. So keeping everything putting together, sir, I request that if your amyloidosis clinic and ASGI, I have requested you several times, sir. Now I am also a senior citizen. I am suffering from this disease and getting treated by all of you, sir. It is I am not able to manage autologous stem cell transplant. I had already told you before. So I am trying now, sir, to manage with great difficulties. But sir, I request that if ASGI can be made part of the amyloidosis clinic of image, I shall be grateful. And we will hand over and we will work as a volunteer. We want to create the database across the country, West Bengal chapter, Bihar chapter, gradually sir, Uttar Pradesh and also Madhya Pradesh. We will be working. I will work as a volunteer, I assure you, because this is something, sir, I have vowed to myself that we should get out of this as a mission. And by the grace of God, the government is also, sir, now helping us. Dr. John Walsav has come today. That is the testimony of that. And you have so nicely, lucidly, you have clarified, sir. So if you permit your Dr. Mirnal and Dr. Gurlin from your amyloidosis clinic, they can allow us to feed in whatever perception we have. We have around 300, 400 FAQs we have developed in this group. I am grateful that very senior hematologists of the country are in the group, but we are non-medical, sir. As a researcher, when I am stuck once it comes to the medical science and the biology. So I request you, sir, that if we can have, through Government of India, a few centers of excellence, at least in metropolitan cities like Amrita, if they can expand their bases. I had requested them also to take over this. So I again request you, sir, sincerely to think that if ASGI can be taken over by Image or merged with the amyloidosis clinic, we will continue to work as volunteer. And this is my passion, teaching, learning, and contributing for the society. I will continue to do that. But you and Pankaj Malhotra sahab, on all the doctors, I am requesting that sir, it is now becoming a more technical type of situation where our our knowledge is getting confused, sir, because we go to Facebook, we go to different places in the social media, and all are suffering. Even in USA, there are patients for more than 10 years. They are suffering the same way as we are suffering. Everybody is looking for some fast track solution, but it's not happening, sir, and it's not going to happen as you have rightly said, sir. I request number one, sir, please help us in establishing a regulatory framework with Government of India. A. B, sir, help us in having a proper partnership with the amyloidosis clinic, the vertical of the image. B. And C, sir, please allow us to feed you with our kind of 18, 19 patients with our problems or the real time, whatever the symptoms that are emerging. With these considerations, I request you to help us. And now I will request you to allow Madam Udita to share the vote of thanks. Sir, she has been working 20 hours a day for last 3 days. And because of her, sir, whatever we will be able to produce these knowledge products with her help and the help of all ASGI members, we have been able to do it. And I had my chemotherapy session with Dr. Riyaz sir whole day today. So I was not able to be in proper state of mind to really contribute. And grateful to you, sir, grateful to Image, grateful to all the doctors, grateful to Dr. Gurlin, grateful to Dr. Vivek, and every doctor who is present or not, we all are able to create and sensitize this amyloidosis in this country. And we hope one day we shall have more patients from West in India than ourselves going to the West. Thank you, sir. With this, I wanted to express my gratitude to all of my colleagues in ASGI and to you, sir. And now you can permit Madam Navodita for the vote of thanks. Thank you, sir.
Hello. I would like to thank everyone present in the meeting, as everyone here has made it possible to make this webinar a success. Thank you so much for that. And I would like to extend my thanks to Dr. Uday for attending the meeting and making it a success. Mostly, I would like to thank our partner Image for their help and assistance. Further, I would like to thank Dr. Atul Janwal from the Health Department, Dr. B.S. Vivek, and Dr. Gurleen Oberoi for clearing all our questions and making the patient and their family members give a better understanding of the disease. Thank you so much for that. Furthermore, I would like to thank Dr. Satish Chandra for his tireless effort to make this program a success, and the entire team of ASGI for their support and contribution. All the data and the video recording will be shared in the group of ASGI. So I would suggest everyone to connect there, and a link of social media platforms will be shared in the group, so everyone can connect there and see the activities from the social media accounts. And in the end, I would like to ask the members if they can switch on their camera so we can have one photography session to document this program.
I am Rita Jain from Delhi. I am not Sonali Jain. I am Rita Jain. Sonali Jain is my laptop name. I am amyloidosis, suffering from AL amyloidosis, heart, GI, and neuropathy.
Yes, we are done with the photo shoot, photography session. Miss Shalini, आपको कुछ कहना है? Ma'am, you can speak.
Who, me? Me?
Yes, ma'am. Yes, ma'am. You want to say something?
Who, me?
Yes, ma'am.
Yeah, I am Rita Jain from New Delhi.
Sorry. Yeah.
Rita Jain. I'm not Sonali Jain. Sonali Jain is my laptop name.
Okay.
My treatment is going
Yes,
on in Max Saket. Dr. Riaz Ahmed is my hematologist. He's diagnosed in this June. I was suffering for 2 years. Heart problem, gut problem, neuro problem, but no one can trace out it. Treating my different ways. But this June, 20th June, so many tests, after so many tests in May and June, it is diagnosis. It is AL amyloidosis. मेरा रेक्टल एंड फैट पैथ का वो हुआ था बायोप्सी, उससे पता लगा। एंड मैंने स्पेक्ट्रो टेस्ट भी कराया था उधर टोरंटो में, वहां से भी एल एमलोइडोसिस पता लगा। तो हार्ट काफी इन्वॉल्व है, एंटी प्रोबीएनडी भी 2300 समथिंग है, 65 है एंटी प्रो टेस्ट जो होता है हार्ट का। एंड जीआई इन्वॉल्व है, काफी लूज मोशन होते थे पहले। एंड न्यूरोपैथी है, कार्पल टनल की बहुत प्रॉब्लम है, सो नहीं पाती हूँ रात को, हाथ सुन्न हो जाता है। अभी मेरे को डारा वीसीडी का ट्रीटमेंट चल रहा है, 4 महीने से स्पोर्ट मंथ चल रहा है। अभी डॉक्टर कह रहे हैं 6 मंथ तक कंटिन्यूस चलेगा, एवरी वीक होता है। आज भी मैं एडमिट थी डे केयर में, अभी शाम को ही आई हूँ मैं। एंड मेरा कापा लांबाड़ा रेशियो भी 2 महीने बाद टेस्ट कराया था ट्रीटमेंट के, तो वो रेशियो इन बिटवीन आ गया। तो कापा लम्बा का रेशो बढ़ा हुआ था, कापा लम्बा वो अब रेशो आ गया, मेरे रेशो में काफी कम हो गया, मतलब अंडर कंट्रोल है। डॉक्टर वाज वेरी हैप्पी। तो फिर वो बोल रहे हैं कि हम 6 मंथ कंटिन्यूअस यही ट्रीटमेंट करेंगे, अब खाली डारा 1 वीक छोड़कर 1 वीक है, मतलब ट्वाइस इन अ मंथ है। एंड वीसीडी चल रहा है पूरा ट्रीटमेंट, आज भी ट्रीटमेंट लेकर आई हूँ मैं, एंड आई एम फीलिंग बेटर। और उन्होंने उसके लिए स्टेम सेल ट्रांसप्लांट के लिए बोले कि यू आर नॉट एलिजिबल फॉर दिस। और कार्डिक फंक्शन भी पहले से बेटर है। डॉक्टर वीके चोपड़ा मेरे कार्डियोलॉजिस्ट हैं, वेरी गुड डॉक्टर। हार्ट की फंक्शनिंग भी बेटर हुई है। अभी 2D इको कराया था दोबारा, उसमें हार्ट का पहले 40% था जो फंक्शन, अब डॉक्टर बोल रहे हैं 55 to 60 हो गया है। जो हार्ट का मसल है वो थोड़ा सॉफ्ट हुआ है थोड़ा। तो बस ये न्यूरो का मेरे को कार्पल टनल का बहुत ज्यादा प्रॉब्लम है। अभी हार्ट सांस भी, ब्रीदिंग में भी थोड़ा आराम है, अब इतना नहीं फूलता सांस लेने में। डॉक्टर ने थोड़ा वॉक करने को बोला है, तो आधा किलोमीटर वॉक करती हूँ तो थोड़ा थक जाती हूँ, बैठ जाती हूँ बस। और सांस नहीं फूलता, पहले सांस फूलता था काफी सीढ़ी वीढ़ी चढ़ने में, चलने में, अब वो नहीं है सब। मैं अपना काम खुद कर पा रही हूँ, सारा खुद कर लेती हूँ खुद से। थोड़ा सा कार भी ड्राइव करने लगी हूँ, पहले नहीं करती थी बिल्कुल। तो ये बस मेरे को कार्पल टनल, हाथ बहुत सुन्न होता है, न्यूरो का थोड़ा प्रॉब्लम है और ट्रीटमेंट चल रहा है। थोड़े थोड़े जो साइड इफेक्ट हैं होते हैं। नींद नहीं आती, तो नींद नहीं आती मेरे को, नींद बहुत कम आती है। अगर नींद अच्छे से आ जाए तो मैं बहुत अच्छा हील कर जाऊँ, मेरी बॉडी खुद हील कर ले अपने आप को। मैं मेडिटेशन भी करती हूँ, चैंटिंग भी करती हूँ आजकल। तो वो सबसे भी मेरे को बहुत फर्क लग रहा है अंदर से, अपने आप से। मतलब फील गुड फैक्टर होता है, 1-2 घंटा चैंटिंग करती हूँ, कुछ अपना जाप होता है वो, जो मेरे को बहुत स्ट्रॉन्ग फील करा रहा है अंदर से। वो हमारा भक्तांबर का जाप होता है, हम जैन हैं, 45 श्लोक का, मैं लोगों को बोलूंगी वो जरूर करें। रियली आई एम फीलिंग बहुत अच्छे रिजल्ट उसके मेरे को देखने को मिले। नो डाउट कि ट्रीटमेंट बहुत अच्छा चल रहा है, लेकिन मेरे को उससे भी 50% ट्रीटमेंट एंड 50% मेरी चैंटिंग मेरे को बहुत हेल्प कर रही है। बिलीव इट। थैंक यू।
Thank you so much. Now we'll end the meeting. Thank you so much everyone for joining.
Thank you, ma'am.
Thank you all. Thank you particularly to Dr. Vivek and Dr. Gurleen. Thank you.